Oh, okay. Thank you very much. My name is Dathini Hamina. I am a postgraduate student in University Center for Nursing Studies, University Technology, Mara. It's interesting for me to present this case study. It's actually a study we have done to drive policy change. It's one of the outputs for my PhD. The title is Effect of SMS-Delivered Health Education Messages on Infant Immunization Coverage and Timeliness in Maiduguri. Maiduguri is in Nigeria. Now, as a way of introduction, we know that infectious diseases are one of the leading causes of morbidity and mortality among infants. But we know that is even more prevalent in developing countries. For example, evidence have shown that 99% of vaccine-preventable deaths happen in low and middle-income countries. That is worrisome. But the good news is that immunization has been reported to reduce this infant mortality. And then a lot of organizations came up to give a benchmark target for immunization. For example, immunization coverage the target is said that every country should be able to attain 90% immunization coverage. The problem now lies in our country, Nigeria. As World Organization reported in 2018, that only 25% of immunization coverage is achieved in Nigeria. So 25%, the target from a target of 90%, and we know that this is one of the leading causes of mortality and morbidity among infants and children under 5. So it becomes a cause of worry, a source of concern for us. It's even more worrisome when we realize that out of that 25%, only 25% were timely with their vaccines. Now, for example, those who are covered, very few, and those who are even time. And we know that timeliness of vaccine is very important for us to reduce the chances of these children contracting this vaccine-preventable disease. By 2021, evidence have even shown a drop in that coverage to about 23%. Now, there are different studies that have been conducted. For example, a study by Adeshina et al. 2024 reported that there is an increase of unimmunized children, and this is attributed to also increase in fertility rate, and as well as so many factors, which I will mention later. For example, 2024, the document reported that over the past 5 years, children who are unimmunized increased from 3 to 6.2 million over the past 5 years. Now, within Nigeria, evidence have shown that there is a lot of disparity between regions. Now, the region where we did this study is the northern part of the country. The northern part of the country is the poorer part of the country, and social determinant of health indicators are poor in those areas. And these are areas that we have high fertility rate of, okay? And these are the areas that we have very low immunization coverage, and mostly is attributed to some of the misconception, because the northern part is predominantly an Islamic community. They don't like anything that has to do with, for example, pork meat, and the insinuation that some of the preservatives or vaccines are associated with. So there are a lot of myths and a lot of misconceptions around it and the northern part. And there are a lot of myths that have to do with, for example, this is a strategy from the Western world to reduce our population, to cause infertility. So there are a lot of issues. This is one of the reasons why we're seeing that low coverage of immunization. Now, for my study location, Borno State particularly, now, where does the problem lies? Because even the coverage is lower than the national coverage. The demographic health survey reported that Borno State have immunization coverage of 19%. Little wonder is the northern part of the country, and we're having that problem within that region. The last case of polio, before who declared Nigeria polio-free, was in Borno State, and these are attributed to some of the problems with vaccine uptake. Now, the problem again is, as part of the hospital policy or government policy, all children who are born within the hospital are expected to receive the first antigen at birth, the antigen administered at birth before they are discharged home. Hence, we're seeing evidence showing that about 62.5% of children receive the first antigen at birth. But the problem lies that after they are discharged home, return back to the facility becomes a problem, because evidence shows that from 62.5, when by 15 months you'll be receiving the measles booster dose, the coverage drops to about 6.6. This is really worrisome. Some of the reasons for this non-adherence, as evidence have shown, is forgetfulness, lack of knowledge regarding the vaccine, how it works, the myths and misconceptions surrounding it, previous immunization experience, such as adverse effect, family and social influences, especially patriarchal, where the male dominance play a role. However, despite this, a lot of issues. Actually, our study focused on knowledge gap. What we want to do, we embark on the nurse-led initiative, a research work, to see how we can bring out a creative idea that will educate people in a cost-effective way, so that it will have a larger coverage of people. And so what we thought of was to move away from the routine practice, which is when people come for immunization clinic before you educate them on immunization. So we moved away from that. We wanted to see how we can incorporate the use of mobile health in dissemination of health information. So when we set out, because we wanted to have evidence that will drive our initiative, drive our policy. So we set out to achieve these objectives. We wanted to know the immunization coverage like in Maiduguri, Borno State, between the 6th, 10th, and 14th. We excluded the at birth because there's already an interference with the hospital policy. So, and we just limited it as a preliminary study to the 6th and 10th immunization schedule. We look at the timeliness, we look at the coverage, and also the barriers, how SMS-delivered health education can reduce barriers to immunization. So when we did a two-arm quasi experimental study. We took the control group and also an intervention group. So we randomized them and the study location, and we carried out our intervention in Maiduguri. It's interesting to note that Maiduguri has a population of about 5.8 million people, one of the largest northern states that we have. So what we did was we looked at parents of infants who are presenting 4 weeks less than or equals to 4 weeks, because we wanted to give enough time for the intervention to know its impact. And we also looked at parents, either father or mother, who have a mobile phone, and we also who have no indication to relocate within the 6 months. And for babies, who are twin, because we don't want contamination, we just look at the eldest as the index of it. We exclude them if they are less than 18 to consent for us. And we also excluded them if they cannot write or they cannot read messages that were sent in English and Hausa. So we were limited to the most common language that is spoken around the area. So this is our intervention. What we did was we tried to see, we adopted a UNICEF health immunization messages, fact MS messages, that are used for dispelling myths and misconceptions. So we did that. Send the messages to the experimental group, and then the control group, we allowed them to continue with the normal hospital routine practice of educating them in the facility. On enrollment, what we did after obtaining ethics, we obtained ethics and consent. So we enrolled our participants from birth up to 4 weeks, and then we delivered our intervention, which is the SMS reminder at interval. We send those educational messages to them 1 week to the immunization due date, so as to help instill that confidence in vaccine and dispel some of the myths and misconceptions. So on enrollment, we administered a short survey. The short survey assesses barriers to immunization. We adapted that to our context and translated it to our common language here. We use that file process and other process to achieve that. So we then intervene at 6 weeks, 10 weeks, 14 weeks, 1 week to the due date of the immunization. And at the end line, we also, that after the 14th week immunization, we still administered our short survey to determine the effect of that on barriers to immunization. So we did use our statistical analysis to find findings out. This is what we found, and that's what was interesting to us. what we found is that the immunization health education messages improved coverage of immunization, as we can see here. Immunization at 6 weeks, at 10 weeks, and at 14 weeks. These are health education messages sent real time to the patients, to the clients, their parents, or their legal guardians. And what we notice is that there is a significant improvement of immunization coverage. Much more interesting is that at the 6th week, we saw a little bit of hesitance from the respondent, and so we are seeing a little bit improvement. But with time, over time, we're seeing how it becomes even more significant. So this shows that when this continues over time, people get used to it, it has a way of improving immunization coverage. For timeliness, it was interesting to also note that for those who were covered, it also improved timeliness. So it reduces the risks or the chances that children can be infected because of delay in receiving immunization. Now, one thing we also look at again, because we know that the northern part of the country is male-dominated, not male-dominated per se, but we have a particular form of system where the man is the head of the family and the absolute head. And what his decision is regarding including healthcare seeking decision has to be respected by the woman. So in a way, the women have little to contribute as far as the children immunizations are concerned. And that's why we also look at what role does this father, we wanted to find those evidence. Does the father and the mother involving them in immunization? Because if the fathers are adequately informed, that will help dispel, they make the decision. So what we saw was interesting to us. For the male, just as we insinuated, this is what we found, that for coverage, for children whose messages were sent, health education messages were sent to the fathers, had improved better compared to those who were sent to the mothers. Initially, we saw a significant improvement. So what we are now envisaging could be that these women could hide and go and give vaccine to the children, but the children, because they are pentavalent vaccine, one of the adverse effects, the children cries a lot because of pain. The husband probably will know at the end of the day, and we saw a drastic reduction over time. So this evidence supports and tells us that when you involve the father, not just the mother, because in the immunization clinic, unfortunately, the father would just permit the woman go to the immunization clinic. But the mother will be the one to receive the health education traditionally given at the child health welfare clinic as well. So what we did by distance via mobile health intervention, why can't we now target these male partners? And this is what we did. And this is what evidence has shown to us. Barriers, we also saw that there was a significant improvement or reduction in barriers. What is obvious, because if the father agrees, the mothers in women in northern Nigeria, a good number, don't work. So the father will give the transport money, reducing barriers. He will encourage, he will support the woman. So we saw access, concern, and importance barriers improves. Although concern, there was an improvement, but not statistically significant. And we don't expect it anyway to be statistical, because concern, these are something that are founded in belief. It takes time for us to clear it up. But it shows that there was improvement, even though the improvement of concern was not statistically safe, but it shows a promising outcome. So how does this become significant for our practice? Promotion of immunization coverage and reduction of vaccine preventable disease. We found that it will be key when children begin to receive vaccine. We also provide an easy to reach medium for transmitting immunization messages to clients. We know globally there's over-dependence on mobile devices. People concentrate on their mobile device more than, so when we have this, it becomes easy for us to transmit those messages and to reach them at their places of work and business in real time. Okay, and this will help lead to reduction of vaccine preventable disease, and infant and child mortality obviously will reduce. So what are the lessons learned and our sustainability? The challenges we saw is that we only limited this to the 6, 10, and 14-week immunization schedule. Again, the long-term impact of the SMS education were not evaluated because of time. So this is one area that it can go to actually look at people, number of children coming down with vaccine preventable disease, and automation of those SMS messages. I think that will go a long way, but because we are pilot testing, we did not automate those SMS. Now, the lessons learned, SMS-Delivered health education, we now know that it can significantly improve immunization outcome, and intervention can promote health equity by improving access to immunization services. And involving men, we found that is also significant in improving immunization outcome. Hence, we are at the moment advocating that Nigeria can leverage on the vast distribution of mobile phone to provide health preventive information regarding vaccine immunization. It's interesting to know that Nigeria has a vast distribution of active mobile phone users, both at the rural and in the urban centers. Now, challenges in practice and perspective, there's a need to embrace technology. This is what we are advocating to help dissemination of health intervention messages. So traditional methods of health educating the women when they are in the immunization clinic has proved to be not effective because we have compared that to the control, and that involving men is fundamental. So there is a push at the moment for inclusion of SMS, not just health education, because what we did, we also did that of the SMS reminder and health education. So we are pushing for inclusion of SMS health reminder proactively and to parents to help them get their children immunized. Now, upstream, social determinants of health we are looking at is education. Because of the growing dependence of mobile devices, we see this as an opportunity to explore, to disseminate those health information to reach the wide coverage of audience, and then we can adequately inform our public about and be able to make informed decisions, most often in the right direction with regards to the immunization coverage. And it's also important to introduce such information to local languages that can easily be comprehensible to our people. So for accessibility, enlightened communities we know are likely to access health preventive services, in this case immunization, and that men are important and crucial factor to be considered. Thank you very much.